Okay, good afternoon, everyone. We're going to go ahead and get started. It's around 12 o'clock on my watch. Welcome to Medicine Grand Rounds. My name is Vinny Chopra. I'm the chair of the Department of Medicine, and it is my pleasure to moderate our session today. As a reminder, CME and mock credit is available through that QR code. So if you have not scanned it yet, please do and follow those prompts. For those of you who are online, we do remain hybrid in our format, but I highly recommend that you consider coming in person. It's just a very different sense of community, interaction with our speakers, and I think a more enjoyable event. Plus, we do give you lunch. So if you can come, please come. We're in RC2 in Krugman Hall, as always. A quick reminder of what lies ahead for Grand Rounds. Next week is a really special week on April 19th. Philippe Sands is here from London. Mr. Sands is an international human rights lawyer. He actually has a faculty appointment at the University College of London and at Harvard Law School. He's written multiple books, and he focuses a lot on human rights in areas of crisis. So his talk next week is entitled On Genocide and Crimes Against Humanity, from East West Street to the Rohingya and to Ukraine. So if you can join, please do. I imagine it would be a wonderful talk. April 26th, we are welcoming one of our own, Dr. Pratiti Kazani, from the Division of Cardiology here at CU, and she's going to focus on addressing ethical challenges in heart transplantation. So two very good talks coming up next 2 weeks. And again, if you can't come in person, please do. It is now my pleasure to introduce to you Dr. Moreland, who is also one of our own and here for Grand Rounds today. I'm going to hold up Dr. Moreland's CV. It's fat and thick because he has done a lot in his life, but I will give you kind of the skinny version of his many accomplishments. Dr. Moreland is professor of medicine and orthopedics. He has a primary appointment in the Division of Rheumatology in our department. He completed his undergraduate studies at West Liberty University in West Virginia, then earned his MD from West Virginia University in Morgantown, West Virginia, and completed his IM residency and also chief year at the West Virginia University Medical Center. In 1987, he moved to the University of Alabama, where he completed his rheumatology fellowship. He stayed on faculty at UAB until 2007, where he rose to the ranks to become a full professor of medicine. In 2007, he was recruited as the division chief of rheumatology and clinical immunology at the University of Pittsburgh. He worked very closely at the time with Dean Riley, who was then Chair Riley at University of Pittsburgh. We were fortunate to recruit him to CU in 2020, and as Larry and I were talking, he arrived here in April, almost, was it 3 years to the date now in terms of his anniversary, where he has now risen through the ranks as well as professor of medicine in the Division of Rheumatology and Orthopedics. Dr. Moreland's research has been continuously funded by the NIH and industry for decades. His primary focus is on clinical trials on novel therapeutic approaches for autoimmune diseases, with a primary focus on RA, but also lupus and osteoarthritis. He was a lead investigator of the early biologic trials in refractory rheumatoid arthritis in the 1990s, and his research is truly translational. It extends mechanisms of disease into clinical treatment paradigms, and it interestingly has a strong emphasis on training junior investigators for clinical research careers. He is co-PI on the Joint Biology Program here at CU. He has published over 330 peer-reviewed papers in top-tier journals, including New England Journal of Medicine, the Journal of Rheumatology, and JCR, among others. And in addition to his scholarship, he is an editor, reviewer, or study section in, I counted, well over 30 unique venues. So it's suffice for me to say he's an international expert in the field of RA. He's given over 100 invited external lectures in medicine grand rounds, rheumatology grand rounds, and national and international meetings. We are fortunate in him giving grand rounds to us today. Please join me in welcoming Dr. Moreland for his talk entitled Rheumatoid Arthritis, Update on Treatment Strategies. Larry?
Thank you very much, Vineet, for that kind introduction. What I'd like to do today is most often give you the 50,000 view of some of these concepts, but on a couple occasions, I'm going to dive into the weeds, and I'll let you know when I'm diving into the weeds as opposed to looking at the bigger view. A couple disclosures, none that are relevant to today's talk that will influence what I say or don't say today. The objectives, quite frankly, are to illustrate to you that this disease is a heterogeneous group of diseases and to illustrate the systemic features and that we have therapeutic options and strategies that can put this disease into remission. The reason I emphasize this is we often see a young woman coming to see us who has a mother or grandmother or a friend who has rheumatoid arthritis and can then have in the back of their mind what they may or may not see. So the emphasis of this with patients is I've got the tools in my toolbox to put you into remission and make you a lot better. Having said that, as Vineet mentioned, have been doing this for a few decades, and I have the fortunate pleasure of seeing the changes that have occurred in the last 20 years, from basically non-specific, largely ineffective therapies to where we can put this disease in remission. I'm going to give you the most positive view today and not emphasize some of our unmet needs, except at the end, I'm going to talk about some hope for the future with some new therapeutic options. So let me start with the case JS, who saw me about a year ago. 30-year-old woman presented to her primary care provider with some hand and wrist pain for 3 months, had some morning stiffness, and she'd had some nonspecific arthralgias for several years, but nothing that caused her to do anything to seek help. She had no other symptoms to suggest any other serious problems, such as rash, muscle weakness, mouth sores. She had just had 8 months earlier a son. She works as a nurse. That was her first child. She's married. Her provider did a few blood tests, and they were somewhat nonspecific, slightly anemic, slightly positive rheumatoid factor, slightly positive ANA, and a little bit of a centrate that was elevated. So when she saw me 3 months after the referral, she had active synovitis that one could detect of several joints, including her MCP joints, wrists, knee joints, had normal strength, normal range of motion, and her blood count had changed a little bit. She was still anemic, had an elevated platelet count, and her SED rate and CRP were more elevated than they were 3 months earlier, and she had a normal urinalysis. She had a lot of positive serological studies, which were helpful in making the diagnosis. Rheumatoid factor, CCP were positive, ANA was positive at 1 to 320, and her Sjogren's antibodies, Rho and LA, were positive. She had a negative studies looking for lupus, such as the autoantibodies and complements. Chest x-ray was normal. And just basically several months into this history, as far as presenting to a primary provider, her x-ray film showed damage. She had evidence of periarticular osteopenia, had erosions of the ulnar styloid and the fifth MTP joints bilaterally. So this patient, as I'm going to refer back to on a couple of occasions throughout the talk, represents a common disease. Rheumatoid arthritis is the most common immune disease that we see in rheumatology. Depending on who you believe, it's 0.5 to 1% of the world wide, higher in indigenous Northern Americans. And there's two peaks, one like in her, a young woman, and two in people who are older onset, over 60, more commonly men. But the cumulative life risk is, as you can see, more in women than men, but it's not just a woman's disease. So I'm not going to go into the weeds here, but basically the concept is, in the right genetic host, patients are exposed to something several years prior to presentation that triggers the immune system to become active. So the most important genetic factor that we've noted for 2 or 3 decades now is the HLA-DR beta 4. But GWAS studies done in patients who are seropositive show you that there's over 100 different loci, suggesting a heterogeneous group of diseases. And the most important risk factor that's been identified to date is tobacco smoking, that can stimulate the CCP antibodies in the lung, and probably accounts for 1/5 of the patients who develop rheumatoid arthritis. Many people in our division and elsewhere are actively looking for those other causes. We have evidence that the periodontal disease and evidence from some GI organisms that they may also be the inciting agent. The concept here is that 5, 10, 15 years before LS presented to us, she developed pre-RA. She was exposed to some environmental agent, we'll never know what, most likely, and in the right genetic host, developed a prolonged period of pre-RA. I'm here today to talk to you about this little part over here on the right after she's really developed RA. But this is obviously an area of intense interest, and many people in our division are working hard to figure out what causes this and trying to put the rest of us out of business so that we don't have to see patients who develop this. I'm going to talk about three hallmarks today. One is the hallmark of rheumatoid arthritis is synovitis. Two is autoantibodies, and three is systemic manifestation. So let me walk you through the first hallmark here. All of us, if we are young and healthy and don't have osteoarthritis or other problems, have in our diarthroidal joints a very thin lining called the synovium. It's there to provide nutrients to the joint and keep our joints healthy. However, with rheumatoid arthritis, this becomes inflamed, enlarged, and starts to grow and secrete a variety of different mediators that ends up resulting then in joint damage. And if you were to biopsy this tissue, you would see more than one pathology, but in this particular biopsy to illustrate, there's lots of lymphocytes and B cells. One of the most important things that has been described in the last few years is our European colleagues are ahead of us. They have a system in place where they biopsy synovial tissue in everybody with early RA. They get a wrist or a knee biopsy. And what they have illustrated here in publications just a few years ago, that if you take hundreds of patients with early RA and you biopsy the synovium, you see three different pathotypes: post-immune, more fibroblastic, more diffuse myeloid macrophage, and the most common being B cells. So this suggests, just on the pathology of the tissue from these early RA patients, there are divergent pathogenic and activation pathways going on in our disease. The patients don't present to us and say, by the way, this is my pathway. They present the way Ms. LS did. And this just illustrates what one would see as an example in early RA is you see these erosions of the ulnar styloid and the 5th MTP joint, as I illustrated with her. If untreated or untreated successfully, this is what will happen in someone with just a few months of RA, 2 or 3 years of RA, and 10 years. So to give you a picture, this is a disease associated not only with significant function problems, significant problems with pain, but in the late 90s, the talk would go around that this disease is associated with an increased mortality, suggesting that patients had a decreased lifespan of 5 to 10 years. And I'm going to talk to you about some of those causes. We've made a big impact in cardiovascular disease, but we still have a long ways to go, especially with pulmonary disease. The second hallmark of rheumatoid arthritis is autoantibodies. Autoantibodies in about 70% of patients if you're a good rheumatologist and not overdiagnosing RA in people who are seronegative. As I mentioned to you earlier, these may exist for several years, several decades prior to the onset of clinical manifestations of RA. And some work that one of my fellows and medical students did at Pitt a few years ago showed that 17% of Caucasians have a positive ANA who also have rheumatoid, and 6% have positive SSA. My point here is that we compared this to our African-American registry from Alabama, and 32% of African Americans have a positive ANA, and 14% have a positive SSA. The importance of this is that patients who have childbearing potential have the ability to have a child that may have neonatal lupus and congenital heart block, which can be a devastating outcome. So this is a number that one needs to keep in mind when you're seeing a young lady of childbearing potential, to talk to them about the possibility of whether they might be at risk for developing this. So how do you make this diagnosis? Well, the good news is it still requires a trained clinician, rheumatologist, to do a careful history and physical, because I needed to rule out lupus and a few other things in this patient when I saw her. So I ordered a panel of blood tests, CBC, chem profile, sed-rate CRP, autoantibodies, urinalysis, and then I got x-ray films of her hands and wrists, and I almost always get a chest x-ray because, as you'll see later, pulmonary manifestations are one of the biggest challenges we have these days. And if you looked at the American College of Rheumatology guidelines recently and from a few years ago, they segregate patients with RA into sort of mild or more moderate or severe based on what we consider poor prognostic factors. Now, that's not the word I use in patients talking to them, but the bottom line is if you have a high titer rheumatoid factor, high titer CCP, erosions at baseline, and have lots of swollen joints, you don't mess around. You come out with the cornerstone of our treatment. And the third hallmark that I mentioned earlier is systemic manifestations. And that's what's associated with the increased mortality. If you want to read a couple articles, there's a couple articles that have been published in the New England Journal in the last few months. This one was from Gary Firestein and Ellen Grabelisi, a summary of the pathogenesis and a little bit on the clinical manifestations. But I borrowed their picture because it was better than the one I had before. But it illustrates that this multi-system can be from head to toe. I'm going to talk about multimorbidity in the second part of my talk. But as I said earlier, in the late 90s, the excess mortality was palpable. The waiting room was full of people who were coming from the orthopedic surgeons. Now I can practice medicine without even talking to the orthopedic surgeons on most weeks and months. So just to give you a brief view, and I'm going to come back to this in the second part of the talk, what are these manifestations from a systemic standpoint that several years ago had this excess mortality and we made a dent in it? Number one previously was cardiovascular disease. It's not explained by the traditional risk factors. It's 3 times the risk when you look at all the comers. And extra-articular manifestations and severe disease is a major cause of this. But I'm going to illustrate that many of our medications have made a dent into that, and I'm going to talk about the one that was published recently in the New England Journal that is an outlier. And so here's what's taken up the slack as far as the number one extra-articular disease, and this is lung disease. And when I come back to the second half of the talk, I'm going to talk about multimorbidity, and you'll hear more about lung disease to illustrate the significance of this. So pulmonary disease comes in multiple manifestations, pleural effusions. Patients who smoke have COPD, they have lung disease, but the interstitial lung disease is the part which we have very few medications that are acceptable to make a dent in this. So in 2023, pulmonary disease is the major cause of excess mortality. And just to give you a couple examples, we rarely see vasculitis, but this is a patient who had rheumatoid arthritis several years ago and had vasculitis. And patients who have secondary Sjogren's syndrome can also have significant eye problems, but the eye is another common organ that's involved. And this is a patient with scleromalacia perforans that required our expertise from our ophthalmologist to manage this. So one of the challenges we have when we see patients is to measure the disease activity. We don't have a hemoglobin A1C or a lipid panel or a blood sugar or blood pressure. We have a composite score that's able to take this patient and say their CDI is blank. And so what this is the most common disease activity measure that most rheumatology clinics use, both nationally and internationally, is something called CDI. Number of swollen joints, number of tender joints, 28 joint count, physician global, patient global. We don't use a SED rate or CRP because it's not convenient when you're in the clinic. The patient usually gets that after the visit. So it's easy to calculate, but it requires somebody who knows how to do joint counts and not overestimate what they are. And it's important that the same person does them at each visit because it can vary from person to person. So there's a lot in our literature that talks about treat to target. And when you look at the CDI, if you have a score of 0 to 2.8, you're in remission. If you have a 2.9 to 10, you're in low activity. And if it's 10.1 to 22, it's moderate. All it takes is a patient with a little bit of fibromyalgia with a score of 10 to take you from remission to moderate activity. We'll come back to that because that's a challenge and an opportunity as we go forward, because I think many clinicians are making decisions to change therapies with disease-modifying therapies based on pain that is not related to their active RA. So let me dive a little bit then into the therapies. And these are the tools that we have in our toolbox. On the left, the traditional disease-modifying drugs, and I'm not going to say anything about sulfasalazine or hydroxychloroquine, except in combination treatment. Methotrexate is the gold standard for somebody with early RA with moderate disease activity. I'm going to focus on that because that's a major issue in women of childbearing potential. Then I'm going to dive into the biologics and the JAK inhibitors. In addition, we've been hearing about biosimilars for the past several years. As you can see here on the right, many of these were approved 4, 5, 6 years ago, but lawyers and patent issues have kept them on the sidelines. We now have here, I think, 15 biosimilars, and the first one that's approved by the FDA as interchangeable biosimilars will be on the market later this year. We were hopeful that these would come on the market to bring down the price, but again, the lawyers have kept them to the sidelines, but not forever. So it's important when you see a patient like JS that when you make the diagnosis, you talk to them in the positive manner that I have the tools in the toolbox to put their disease in remission. And I'm going to start methotrexate unless there's a reason not to start it. And as you'll see later in some other presentation, when I talk about a study that I was part of, about 30% of patients, that's all they need. They won't need anything else, but 70% will need something more than that. And then we'll talk about what you add on if you don't respond to methotrexate. So it's the cornerstone for people with moderate to severe RA, but there are a few contraindications. We try not to give it to people who drink excessively. I'm not going to define that in this audience, that varies. But the most important thing on this slide is renal insufficiency. I've been involved with a couple legal cases throughout my career, and most often it was because patients had renal insufficiency, took methotrexate, developed pancytopenia, and died of overwhelming infection. So when I get the blood test back, the first one I look at is creatinine to make sure they're not have some renal insufficiency. And this is really important in older individuals. You start at 15, escalate to 20 to 25. It may take 2 to 3 months before the patients actually feel better. So this is where we get stuck with the prednisone bridge therapy. And once you give a little bit of prednisone, it's hard to take that away from patients, but it's hard to say, I'm going to give you methotrexate, but you have to wait 3 months to get better. So that's the conundrum that we have in initiating methotrexate. The other take-home message is you need to avoid getting pregnant if you're on methotrexate because it is teratogenic. And I'll talk more about that in a couple different venues in a few minutes. So we start methotrexate, we see them back every 3 to 4 months, we check disease activity, monitor for blood tests, and we maximize the dose. And if they have any GI toxicity, we consider going to the sub-Q route. And quite frankly, it's the best way to maximize the blood levels, but that's maybe not the way you want to start with a patient, is to say, I'm going to give you sub-Q methotrexate. And then you try to taper the steroids. And as you taper the steroids, if their disease is still active, then you got to add something else. And this is an old study, but it's a very important study where they randomized patients with early RA to oral methotrexate or sub-Q. And this is a different outcome measure for a clinical trial, ACR20. This is a major difference between those who responded and didn't. And so I have a low threshold for taking somebody and instead of adding a biologic, is to maximize methotrexate, the dose and the interval and how to give it. So switching gears then to the biologics, I'm going to try to give a high level view of most of these. And when I need to get into the weeds, I'll try to get down there. So as Vineet mentioned earlier, I've been involved with the development of biologics in the early days. And in 1998, the first 2 biologics were approved by the FDA, etanercept for RA and infliximab for Crohn's disease. There's 5 on the market. And if you look carefully at the list of biosimilars, there's 15 more on the market. There's a lot of money in these, and that's why many companies have their chests lined up with the biosimilars. This is a chimeric, this is a fusion protein, adalimumab, which is the most common used because they made a deal with everybody in the country to undercut the price of this. And so when you want to start an anti-TNF therapy, it's adalimumab unless you have a really good reason not to do so. So these in the late 90s, early 2000s revolutionized how we treated rheumatoid arthritis. Patients didn't come back and say, I feel a little better. They came back and said, I got my life back. And so we use them as monotherapy, but more often in combination. And I've been a little bit conservative with saying that over 60% have a good clinical response. But I don't want to leave you the message that everybody responds well, because we do have other options we have to use. These were initially approved for RA and bowel disease. Now they're approved for many indications. And I'm going to show you later on that these have decreased the frequency of cardiovascular events in RA, which is, again, as I said earlier, one of the major increased risk of mortality. There are a couple bumps in the road with TNF inhibitors. You want to avoid them in people with active untreated infections, hepatitis B, C, latent TB. Heart failure is a little bit iffy, but there were studies done in the early or the late 90s to try to use these drugs for heart failure, and they showed that it really didn't work, and I'm not sure that they really made them better. The one that you really want to make sure is that you don't give it to patients who have any history of or history of multiple sclerosis or optic neuritis. There's some evidence that they may make that worse. Melanoma is a question mark. I personally don't think they make melanoma worse. There's a paper that says it does and several that says it doesn't, and everybody can Google as well as anybody else. And so if somebody's got a history of melanoma, I steer away from these. By and large, they're relatively safe. Our nurses and our faculty are attuned to the issues with TNF inhibitors, with infections. We pre-screen them. There are injection site reactions and infusion reactions. There's a few rare things that pop up where patients who have been treated with TNF inhibitors develop other autoimmune diseases like lupus or lupus-like syndromes, psoriasis, or vasculitis. And I want to mention, but not get into the weeds, the issue of immunogenicity, anti-drug antibodies. We typically ignore this and don't talk about it, but it's a huge issue as we go forward. And for example, two of the TNF inhibitors, adalimumab and infliximab, at least 50% of patients develop antibodies to the drug. It becomes ineffective or less effective, and those immune complexes may be associated with infusion reactions or some of the other things I just mentioned. And this is an old study done in 2012 showing that in patients treated with adalimumab, 50% developed antibodies. If you were on methotrexate and you took higher doses, you got it down to about 15%. We typically don't give most of our patients 22.5 or higher. So I am reluctant, although I have to do it sometimes because of insurance, to give Humira or adalimumab as monotherapy, because there's a good chance they're going to develop antibodies, and if they lose that response, then you're going to have to switch to something else. So the TNF inhibitors sort of set the stage in the late 90s, early 2000s. It revolutionized how we looked at not only RA, but multiple diseases in the field of autoimmune diseases, not only in rheumatology, but GI and dermatology. A little bit later in the early 2000s, IL-6 blockers came about, and I'm going to talk about tocilizumab. But IL-6 is, if you look at the pathogenesis of RA, it, like TNF, can cause lots of things to happen, autoantibodies, T-cell activation, et cetera, et cetera. So blocking it makes a good, reasonable approach. It has a few more bumps than TNF inhibitors. It can cause neutropenia, hepatic liver enzyme elevations, increased cholesterol, HDL, but so can lots of our other medications because of this lipid paradox and inflammation. But there's probably an increased risk of bacterial infections, minor, but they're there. But a contraindication is anybody with diverticulitis. There's an increased risk of colon perforation. So this is where our history will guide you probably away from IL-6 blockers. And I want to spend a little bit of time talking to you about co-stimulatory blockers, because this is probably the safest biologic we have, and it takes a little bit longer to work. But if you got a patient with any issues that you're worried about with some of the other comorbid conditions, this is the one that I would pull out. And just to briefly explain to the students and house staff, if you haven't seen this, that our immune system is based on the first MHC T cell receptor. And to have the T cells to be fully activated, there's this co-stimulatory process. And CD28 and CD8060 cause a positive T cell activation. And if CTLA4 is expressed on it, it dampens that reaction. And so when patients or people or mice or whomever have an activated T cell, it's angry and causing autoimmune disease. But at the same time that T cell is expressing CD28, it also starts to express CTLA4. So someone in a lab many years ago was smart enough to engineer this fusion protein called abatacept, and its cousin, belatacept, is used for solid organ transplantation. It's a fusion protein that when given to patient, it binds more avidly to this, and it allows then the T cells not to be activated, and it turns down the immune system. When we first used this several years ago, I was shocked that we didn't have lots of side effects. And in fact, we really have no significant adverse events with this agent. The problem is it probably doesn't work quite as good as the TNF inhibitors, and it takes a little bit longer to work. But if you're after safety, this is at the top of your list. And finally, when talking about the biologics, I'm going to talk a little bit about rituximab anti-CD20 monoclonal antibodies. They are approved for autoimmune diseases, including rheumatoid arthritis, ANCA-associated vasculitis, and multiple sclerosis, and also for several lymphoproliferative diseases. In rheumatoid arthritis, they're approved in combination with methotrexate in TNF non-responders. They kill B cells. It's given IV every 6 months. That varies depending on preferences of some investigators as to whether you want to deplete more strongly or not. This one has some side effects to it, and this, in my mind, is given to our RA patients after you failed many of the others. I would imagine the neurologists are using this much sooner in multiple sclerosis because blocking B cells in MS, I think, has been a game changer based on my view from outside the arena on this. It can be associated with infusion reactions. Several infections can occur, possibly related to patients becoming hypogammaglobulinemic. It can reactivate hepatitis B, and in rare cases of PML, but that's extremely rare, but you have to mention it. It's been a challenge with COVID and vaccinations. I would imagine that most of the patients that we take care of that have had bad outcomes have been because we're not been able to give appropriate vaccinations because of the B cell problems. So I think COVID has put a little bit of damper in people's enthusiasm to use this. But having said that, it has revolutionized how we treat ANCA-associated vasculitis and probably MS. Now I want to go from the 50,000 view and get down in the weeds because this is the elephant in the room as far as we are dealing with in rheumatology over the last couple of years. JAK inhibitors. There are 3 on the market. They work by blocking JAK1, JAK2, TYK, and they block lots of cytokines. And so when you look at this, you say, yay, I can cure this disease. I can kill many cytokines with one drug. And there are 3 on the market. There's a couple others that are waiting to get on the market. And these, in my mind, are at least equal to the TNF inhibitors and the others, although there aren't a lot of head-to-head comparisons. And they've been relatively safe. And you can see here they're approved for rheumatoid arthritis, psoriatic arthritis, ulcerative colitis, juvenile idiopathic arthritis. More recently, the second one approved for ankylosing spondylitis. Then there's a whole bunch of others down here that I don't know anything about because that's not what I do for a living. It would make you think you should put one of these in your orange juice every morning and take because it's going to cure whatever helps you. But here's the problem that's occurred. This is the New England Journal article that came out in 2022. There was a mandated study by the FDA when this came on the market several years ago because there was a hint of potential cancers in the package, and there was a hint that patients developed elevated cholesterol levels or lipid levels. So it was a mandated over 4,000 patient study. Patients were randomized to tofacitinib versus TNF inhibitors. The primary co-endpoints were major adverse cardiovascular events, or MACE, or cancers. The study design is listed here, and if there's 2 articles you should read, one is the New England Journal on the review of RA, and this one on the safety of tofacitinib. So these were moderate to severe patients who had failed methotrexate, over 50, had to have at least one cardiovascular risk factor, no prior history of malignancy. We had learned in February of 2019 that tofacitinib at 10 milligrams twice a day gave us a signal for blood clots. So the FDA mandated decreasing the dose to 5 milligrams twice a day. I think the gastroenterologists were using the 10 twice a day. We in rheumatology, not so much. But in February, we went from 10 milligrams twice a day max to 5. And so here's the bottom line. I could show you fancy studies from the figures from the manuscript, but here's the MACE: is either you died of cardiovascular disease or had a non-fatal MI or stroke. Tofacitinib 3.4%, TNF inhibitors 2.5. We're talking thousands of patients, 98 versus 37. Cancer, excluding non-melanoma skin, tofacitinib 4.2, TNF inhibitors 2.9, 122 to 42. It was not inferior to TNF inhibitors. Opportunistic infections, zoster and TB, were higher in the tofacitinib group. This study was done at, I think, 300 sites in 30 countries. So one could imagine the heterogeneity and the clinical expertise in some of these sites. So we got a black box warning in September 2021. The publication came out just a few months ago. And they cited all-cause mortality, MACE, malignancy, and pulmonary emboli. And instead of it being allowed to be used after methotrexate, they said you have to use it after TNF inhibitors. And it applies not just to tofacitinib, but to these other JAK inhibitors. But it doesn't apply to some of the other JAK inhibitors used for psoriasis and myelofibrosis. I'm not an expert in why that happened, and so I don't have an answer. For those of you who in the audience during discussion can talk about this. So what do we do? Well, I was of the belief that if JS came back to see me and didn't respond to methotrexate over the past several years, I would have added a JAK inhibitor instead of a TNF inhibitor if my insurance would have let me, because it's a pill and you can stop it if something happens. But now I can't really talk about it until they have failed a TNF inhibitor. So it's a risk-benefit discussion for the patients already on it. If you've had a history of DVT, probably wouldn't go there. If you're over 65, probably wouldn't go there. And you have to talk about the risk for malignancy. For tofacitinib in this study, for men, the primary cancer was lung, for women was breast. Questions that I don't have answers for is, why did the FDA apply this to all the JAK inhibitors, not just tofacitinib? And why did they apply it to other diseases and why did they not apply it? I think we're going to see a lot of data. And like COVID data, how much of it's good, solid data versus not so good. So back to patient JS. I saw her, made the diagnosis of rheumatoid arthritis. I started her on methotrexate and saw her back on a couple occasions. And then after 4 months, she was doing pretty good relative to where she was. I didn't put her on prednisone. I asked her to hold in there and not take the prednisone. She continued to have 30 minutes of morning stiffness. Her CDAI was 15, which was moderate disease activity. She still had 3 swollen joints, was 12 at baseline. Her SED rate was much better, and her pain was minimal. So in general, she was much better, but she wasn't where I wanted her, she wanted her. So my next choice is to increase the methotrexate to a higher dose, give it sub-Q, or add something else. So let me switch gears then and talk about what we do with people who have failed good doses of methotrexate and good routes. We have the option of triple therapy: plaquenil, sulfasalazine, methotrexate, leflunomide or Arava that I'm not going to say anything more about, and then the TNF inhibitors, costimulatory blockers, and IL-6. And this used to be up there, but since the black box, I haven't taken it off. I still left it there, hoping it'll come back soon. So how do we choose? It's, in general, whatever we choose, the efficacy is about the same. I don't want to get into the weeds of which one's a little better. I've already played my hand on one of that. There are very few head-to-head comparison studies. And as I said earlier, the choice is often dictated by the insurance, and adalimumab has been the winner for the past several years, but the JAK inhibitors did make it there for a while. And no matter what you choose, many patients have a very positive response. As I said earlier, if you take a TNF inhibitor, 60% of the patients are going to have a very positive response, and we're probably going to put them in low disease activity or remission. And if they don't respond to that, then I have these other options to choose. So once this patient has declared themselves that they need to step up, we start with methotrexate and then we add something else if needed. So this is a study, I'm going to give you the high-level view, that was done several years ago. And for those of you interested in the clinical career, it took 10 years from the time the NIH planning grant was funded until the final publication. So if you're looking for a quick publication, clinical trials is not the realm to go. But this was an investigator-initiated study at UAB with our rheumatology colleagues in medicine and the Department of Biostats, funded by 2 NIH grants and a significant grant from Amgen. It's called the TIER trial, and our hypothesis was that the combination of methotrexate and etanercept would be superior to triple combination, the less expensive one, and it would be ideal to give everybody this combination early on and not just give them methotrexate. So it was a 2x2 factorial design done at 44 clinical sites. UCLA and Nebraska and Rain were two of the major clinical sites with private practice groups. So patients with the phenotype of JS, poor prognostic factors, high titer rheumatoid factor erosions were randomized to methotrexate plus etanercept, methotrexate plus sulfasalazine plaquenil, or methotrexate. If after 6 months you were not in remission, you got bumped up to one of the more active treatments because it was unethical to leave you hanging for a 2-year period. The primary outcome is listed here. It's an area under the curve. They all were equal. It didn't matter what you started with. The outcome, the amount of time patients had disease activity that was felt to be amenable to the treatment was the same. So our conclusions were that 28% of patients with early RA, all they needed was methotrexate. So therefore, you don't need to give everybody the kitchen sink. There was no difference between the disease activity score between 48 and 102. And so our hypothesis was not correct. The triple therapy was just as good. There have been 2 other studies done, one in Nebraska and one in across the pond, that showed the same thing. Why are we using this in all patients? Well, we don't have an advertising campaign, number one. And number two, this is a tough pill to swallow. Sulfasalazine takes a long time before it works, and you're talking about taking lots of pills. So it's probably not, the one that you and I would want to take. However, if our health system runs out of money and we can't take the TNF inhibitors, we have a backup plan that we can use this. And I'm going to show you an example of another study here in a couple minutes that shows something very similar. Now, moving along, because I've got a keen eye to the clock here, I told you before we're going to put patients in remission and we're going to make them feel better. Then we have to decide what we're going to do. And this is somewhat controversial that some colleagues are reluctant to take patients off of medications. But there's several studies on this, and this is the one that gives my point the best, so I'm going to show it. Our colleagues in Austria several years ago did a study where they took these patients, put them in remission with methotrexate and etanercept, and then after several weeks, they randomized them to stop the TNF inhibitor, use the same dose, or use a low dose. What they showed is if you stop the TNF inhibitor, 40% remained in remission. If you used half the dose, it did just as good as a full dose. So to me, if I can put 40% of patients in remission and stop their TNF inhibitor, that's a win. However, there's a lot of pushback from this because patients, once they do well, they may not want to change that paradigm. They want to keep taking it. And if you stop adalimumab and then have to restart it, you have a big issue with potential immunogenicity. I think the most important factor that I look at when I try to do this, if I've had a patient that's been in remission for a year or 2 years, a deep remission, they're more likely going to respond. And also, if they've been seronegative, they probably have a less severe disease anyhow. And if they're not on steroids and pain medicine. So I think there's a subset, and I have that discussion every week with patients, and we talk, and sometimes we don't make any changes. So let me, in the next 10 minutes, hit the high points of the multimorbidity part, and I'm going to talk about 6 of these. Our European colleagues have proposed that there are 44 morbidity challenges that we should tackle, and at the first visit, we should do a checklist on all of those. Well, that's the Cadillac version, but I want to hit the top 6 that I think are important for us as primary care providers and rheumatologists to work on together. Number 1 is cardiovascular disease. It's the most common cause of RA mortality. That accounts for 30 to 40%. I think we made a big dent in that. Cardiovascular disease are much more common in RA versus controls, and systemic inflammation is probably what's driving it. So treat the disease, treat the target, get rid of the inflammation is the bottom line. And the question is, do our disease modifying drugs make a difference? And without going through great detail, the answer is the TNF inhibitors and methotrexate have been shown primarily in observational data, abatacept through forms claims data, tocilizumab, a head-to-head comparison with TNF. So whatever happens to TNF is equal to tocilizumab. And then a study just published, the Target study funded by the NIH, looked at FDG PET CT to look at inflammation in the aorta and carotids. And guess what? That triple therapy looks just as good again. It works and it decreases inflammation in the system. But we have a challenge. We have tofacitinib here that goes against all of this other data. So manage the common risk factors, manage the hyperlipidemia, control the disease, treat the target, and we need to stay tuned as to what happens to JAK inhibitors. I'm not going to go into great detail except to show you that when you have patients who present like this with RA, you're talking about the same kind of prognosis you have with other types of idiopathic pulmonary fibrosis. And probably 2 to 10% of our patients have severe RA-ILD. Subclinical is probably noted in 25%. How do we identify those patients? And how do we understand the pathophysiology so that we don't end up with somebody that has irreversible disease? So lung disease has replaced cardiovascular disease in causing increased mortality and remains an opportunity challenge for us going forward. And there are lots of people at this institution in rheumatology as well as pulmonary that are working on this. And so we hope they get to work quickly as possible. The third thing that I want to talk about, and I wish I had more time to go into this, is mental health and pain. And I use this one study. There's been lots more in the past 9 years, but this is a study from the Brigham Registry for RA, the BRASS. And Yvonne Lee basically segregated her patients into low inflammation, doing well in remission, to minimal inflammation, high pain, and then active inflammation and high pain. The bottom line is that 47% of patients with really no synovitis on exam and their SED rate and CRP normal had high levels of pain. So that suggests then that this is a challenge when we look at these disease activity measures and we look at pain driving what we do next. We now know, based on a lot that's been published in the last couple of years with understanding pain, there's multiple mechanisms, nociceptive coming from the joint that's inflamed, neuropathic and nocioplastic, and this ties in a lot to some of the mental health issues as well. And the slide that I've borrowed from Dan Claw in Michigan, that basically patients often present with a combination of nocioplastic, neuropathic, and centralized pain. So from my perspective, we need to be moving forward to better characterize the pain in our patients, to treat their neuropathic pain or nocioplastic pain, and focus more of our disease activity measures on real inflammation. And so we have more than one target. I don't think the field has moved there yet, but I sense the momentum that the American College of Rheumatology is ready to look at some new outcome measures. And then bone health is one that we talk about, but we often miss the boat in doing anything about it. But people with rheumatoid arthritis have an increased risk of osteoporosis, 25% higher risk of osteoporotic fracture than normal people. There's two things other than the common risk factors that the rest of us have. They have cytokines for several years floating in their system until it boils up and develops into RA. And CCP antibodies have been shown several years ago to be pathogenic in causing bone erosions and osteoporosis. The reason my patient had erosions early on is because she probably had CCP antibodies for several years. So it starts early. And one of the reasons that this came to my attention was several years ago with the CLEAR registry, the African American registry that Dr. Bridges and I put together not quite 2 decades ago. We learned that 55% of our patients who had early RA within 2 years had either osteopenia or worse, 16% osteoporosis, and the mean age was 51 years. So if you look at the society recommendations for when to do DEX scans in RA, there aren't any. And this is a nice article that was just published from one of my colleagues, Josh Baker from Penn, that is proposing that if you're over 50 and you have RA, you should get a DEXA scan. If you're less than 40, you probably need to see some trauma. But this 40 to 50 years of age, if you've had a high ACPA titer at the presentation and you have periarticular osteopenia, you need to be checking, I think, bone densities. And yeah, you may get denied, but it's worth the fight to get somebody to pay $100 for a DEXA scan. Because this is what we want to prevent. We want to prevent the silent fractures of vertebral fractures in patients that we could have prevented it. There's a positive correlation between disease duration and this osteoporosis. It's associated with additional risk and also associated with increased mortality. So osteoporosis screening is crucial for the prevention of this disease, and you need to think about it in a younger patient population, not postmenopausal or older individuals. And even the prevention strategies, almost half the patients don't get the appropriate treatment. As I said earlier, up to 30% of patients will develop osteoporosis during the course of the disease. And I'm going to mention very quickly infections. We think about them a lot. We screen for them, but in conjunction with primary care providers, we need to make sure we're immunizing our patients to try to prevent some of these. And finally, malignancy. What I didn't say early on as one of the causes for the excess mortality, patients with RA, when you look at large cohorts, have an increased risk of Hodgkin's and non-Hodgkin's lymphoma and have an increased risk of lung cancer. Part of that is probably related to the smoking history. Methotrexate probably increases the risk for non-melanoma skin cancers. As I said earlier, there's been really no good data that our targeted biologic therapies increase the risk of cancer. Melanoma is an iffy one. But as you can see here, tofacitinib has put a bump in the road now because we have to have that discussion and we need more data. And finally, before I summarize, I want to make a comment about women's health conditions. The American College of Rheumatology has developed guidelines to help us deal with pregnancy issues and birth control and medication issues. And so this was published in 2020. We've been fortunate to have two people in our division, Dr. Demirel and Dr. Zell, have a major lead in making this a priority for our clinic. So we have 4 ways to make sure that we don't allow a woman, any women of childbearing potential. One is every woman who has not had a sterilizing procedure is given a form every time they come to clinic. They're probably wondering why we're asking about their pregnancy every visit. There's a pop-up box in Epicare. So if you order a drug that's teratogenic, that's the only pop-up we have in our clinic. We have a women's health clinic option that Kristen and Joan will see the patients if they can't see a primary provider or a gynecologist. And probably most important, we have this in the waiting room. It's in black and white, yes, and green and black, as to whether your drug is teratogenic. And we also have it in very clear as to what is a safe and what is not a safe contraceptive method. So in summary, in the last couple minutes, I want to emphasize that rheumatoid arthritis is one of the diseases where there's been a dramatic change in how we went from non-specific treatments now to targeted biologic therapies. My message to the patient is, I've got the tools in my toolbox to put you in remission and put you in low disease activity. I don't tell them about the unmet needs and the opportunities, but the message is, I can put you there. We need the help of our primary providers. I think everybody with RA should be co-managed with a primary care physician and a rheumatologist, recognize the toxicities of the medications, recognize the risk of infections, immunizations, monitor and treat aggressively for cardiovascular disease. Perhaps more importantly is the mental health, pain, and the osteoporosis that we're always sometimes not sure who is tackling that. And pain management and mental health, I think, remains an opportunity where we can make some major impact. But I want to talk about, finally, that I hopefully have left you the message that RA is not one disease. There's several subsets. We know that smoking causes some of the patients' illnesses, but we're still looking for all the other causes. There's autoantibody positive and negative, extra-articular features versus none, erosive disease in the first few years versus no erosions, older versus younger. And finally, in the last 2 slides, to talk about the heterogeneity of the synovial tissue. As I showed you earlier, the Europeans have outlined that there are 3 different pathotypes that we see. We, as part of AMP, that was been funded about 7 years ago, and several of the publications are coming out, have now demonstrated that there are over 70 different cellular activation states and 6 distinct cell types of abundance using RNA-seq. And now we're moving into the second phase of AMP, and we have several people at our institution who are key players in this. And we're going to be taking patients with RA, early RA, people who failed methotrexate. If they have a swollen wrist or swollen knee, we want the tissue, and using new techniques and technologies, including special transcriptomics, want to see if there's something in that tissue that predicts whether you respond to methotrexate, TNF inhibitors, IL-6 inhibitors. And hopefully we're going to have a blood test that correlates with that response, because getting a synovial biopsy is probably not going to be the standard of care. And finally, I want to acknowledge in one big swoop the numerous patients that have participated to allow us to get where we are now with the transformation of RA treatments, the numerous collaborators, and finally, my long friend, Bill Koopman.
Dr. Moreland, thank you for that wonderful talk. I took notes, actually, so you've taught me a little bit as well. Thank you. We have a number of questions. I'm going to start with our chief residents here.
Great talk. I feel like we're always trying to learn more about RA. I'm Marilyn, one of the chief residents. It's interesting that they found these like 70 different phenotypes, but are you seeing in Europe that even just based on those 3 biopsy samples, like more lymphoid predominant or myeloid predominant, that you might change what first, second line after methotrexate therapy you might use? Like if it's lymphoid predominant, start with rituximab instead of the TNF alpha inhibitor?
Well, time obviously didn't permit me to dive into that, but our colleagues in the UK have basically taken that and gotten baseline biopsies and treated patients with IL-6 versus rituximab.
Yeah.
And those with a higher level of B cells clearly responded. And those with very few B cells, some responded and some didn't.
Mm-hmm.
But they haven't looked at the some of the fancy things with RNA-seq and special transcriptomics that we plan on using. The good news is we can take their tissue and do our techniques on that right now. And I didn't submit the grant, but I was part of it, just submitted a proposal today to the Department of Defense to do a randomized controlled trial of patients who are on methotrexate not responding to receive TNF inhibitor or IL-6. And our goal is to look at that synovial tissue to see if there are predictors of which one would respond to either one of those. So this is an area of active research that I think is going to take us from where we throw the dart right now at the board to see which one to use to hopefully precision medicine. But as you might imagine, this doesn't happen overnight. But it's an exciting area to learn that we have this heterogeneity. And I'm just talking about seropositive. We're trying to tackle that as opposed to seronegative, because seronegative, you get into a whole bunch of different pathologies.
Yeah, thanks. Interesting.
We can open it up to the room actually first.
Yeah.
Thanks, Larry. That was a great overview of rheumatoid arthritis treatment. One thing that I always am intrigued by is the data in rheumatoid arthritis about using methotrexate in conjunction with the TNF alpha inhibitors to prevent the development of antibodies against the monoclonal therapy. And thinking about how we utilize that in RA, but we don't necessarily extend that to some of our other diseases like in ankylosing spondylitis, or even my colleagues in IBD who don't use it. And so do you think that's because of a feature of RA that is an antibody forming disease, and these others are just more of an immune regulation issue? Or do you think that there really is a merit to always having methotrexate on board regardless of the indication for the TNF inhibitor?
The short answer is I don't know, but I think this is an area that people are sort of turning their back on, because you don't want to have that as your part of your portfolio, that you're very immunogenic. But as you know, etanercept is our low level. Very few people develop antibodies. I just read an article in the last couple of days with the use of rituximab in MS. 37% of patients have antibodies to rituximab. And that's surprising because rituximab is killing the cells that can make those antibodies. We need safer, we need to have a more comprehensive view as to how frequent these antibodies occur. Are they neutralizing? And we need safer methods other than methotrexate to prevent them.
I don't want to get over.
Thank you. That was a really educational talk. I appreciate it. My primary care team sitting here, I'm going to ask on behalf of them, but they probably know the answers already. But wondering, like with the case you presented, would it have been beneficial if a primary care doc had started her on methotrexate and saved her that 3 months, given the waiting times to get into rheumatology? Should we feel comfortable starting methotrexate for somebody like her, who it seems like was in worse shape when she showed up? And the part two is statin question, given the excess cardiovascular risk, or so should we have a lower threshold for starting statins, or do we assume that with treatment, the cardiovascular risk comes down and they are kind of back, we use our standard measures to decide about statins?
Well, let me take the last question first because it's the least challenging one. I started out with lots of slides and I had to come down to the ones I have, and I had a big section on the lipid paradox. If you take patients like in TIR that had active RA and you treated them with those 3 different treatments, their cholesterols went up, their HDLs went up, their cholesterol levels look worse. And so if you've, and I'm not sure I understand that, but I think I'm reluctant to start statins until after a few months, till things settle down, to I see what their lipid levels are. But I think that's an area that's a little bit of controversy. The short answer to your question is we need to do a better job in getting the patients in to see us sooner. I'd be happy to see them much sooner than 3 months, but that belongs to somebody else.
Puneet's telling me we have time for one more question. No, there was one online question. If you can just briefly touch on colchicine in RA, question mark?
No.
No. Thank you.
Dr. Moreland, thank you again for a lovely talk. I really appreciate it.